All right, so in chapter 40, we're going to talk about disorders of the endocrine system. So already knowing what the endocrine system normally does, we'll talk about what happens when things don't work properly. So in terms of how endocrine disorders can result or arise, they can come from hypersecretion, which can lead to hyperfunction of a tissue. Right? So hypersecretion would be excessive secretion of a hormone causing hyperfunction of that tissue. Like if you have a lot of thyroid hormone being released, and that might lead to hyperfunction of the target tissues for thyroid hormone. Or hyposecretion hypofunction, where you have low hormones being released, right? Low levels of hormones being released, which causes hypofunction or underfunction of that tissue. Or non-responsiveness by target cells. You might have a sufficient amount of hormone, but if the target cells can't respond to that hormone, then that can lead to hypofunction. An example of this would be like type 2 diabetes, where you have a sufficient amount of insulin, but your body cells stop responding to that insulin. So that leads to hypofunction. Now, hypersecretion can come about from things like secreting tumors. So some tumors of glandular tissue can secrete a lot of hormones. Autoimmune disease, where your immune system might attack cells, and cells can actually burst open and cause their hormones to spill out into the body. That can lead to hypersecretion. Or you might have autoimmune disease where antibodies start simulating hormones. Like an antibody might bind to a receptor and it has the same effect as a hormone, even though it's not really a hormone. And that can come from autoimmune disease. Or excessive stimulation of a gland by other trophic signals, like other hormones might stimulate this gland to lead to hypersecretion of a hormone. Now, hyposecretion can come about from failure or congenital absence of a glandular tissue, autoimmune destruction of that tissue, like if you have an autoimmune disease against an endocrine gland or tissue, eventually that can lead to complete absence or partial absence of that tissue. Surgical removal of a gland, it could be iatrogenic, like accidental, or just a lack of normal trophic signals from other glandular tissue. And hyporesponsiveness comes from where tissues don't respond to a given hormone. This could come about where a receptor might be blocked. Like what if there's a drug or an antibody that blocks a receptor? So you might have a sufficient amount of hormone present, but if that receptor is blocked, then it won't have an effect. Or what if you have tissue resistance where cells start to downregulate their receptors? Remember we talked about how if the signal's really loud, right? If you get a lot of hormone being released, cells can start to downregulate their receptors. They can start to remove receptors from the membrane, which means that with less receptors, then you have a weaker response to that hormone, and we can call this tissue resistance. We'll talk about some disorders of tissue resistance in a little bit. Now, what this slide shows then are the disorders of hypofunction and hyperfunction. For hypofunction, this can come about from trauma, surgery, radiation, ischemia to tissues, suppression by exogenous hormones, or even congenital dysgenesis, like it never develops normally. Hyperfunction can come from things like microadenoma, or basically a growth of this glandular tissue that leads to a lot of hormone being released. Or adenomas and adenocarcinomas can also release excessive amounts of hormones. And if it comes from endocrine glands, you might find that an endocrine gland can release an excessive amount of a trophic hormone, which can go on and exert an effect on another target tissue or gland. You might have a secreting tumor or autoimmune stimulation of an endocrine gland. So autoimmune stimulation would be where antibodies can bind to a receptor and they start to simulate what it's like to have that hormone present. An example of this is called Graves' disease, which we'll talk about in a little bit, where it's an autoimmune disease where immune system starts making antibodies against TSH receptors, right? Well, you find TSH receptors on your thyroid gland. So what happens is antibodies start binding to TSH receptors, but when those antibodies bind, they also bind and activate the receptor, which then causes thyroid hormone to be released by your thyroid gland. But it's not because the TSH is binding to the receptor, it's because antibodies are simulating TSH. They're kind of pretending to be like it, right? So they're activating the receptor. So that's autoimmune stimulation. Otherwise, you might get deficiencies in hormone from inadequate trophic hormones, genetic defects in a hormone, like the hormone might not be structured normally to some sort of genetic defect. From autoimmune destruction, where your immune system can start to kill off endocrine glands and tissues, ischemia or lack of blood flow to organ tissue, and non-secreting tumors. Like if a tumor is growing in your thyroid gland and it's starting to impinge on nearby structures, but it's also non-secreting, then you won't get hormone being released. Otherwise, we can actually see that exogenous or ectopic sources of hormones can lead to hyperfunction or hypofunction. What if you had excessive hormone administration, like someone's taking too much of a hormone, exogenously. So that can lead to hyperfunction. Or you might have like a non-endocrine tumor producing hormones. You can have sudden withdrawal of hormones. I'll give you guys an example too, where let's say if you are on glucocorticoids for autoimmune disease and you've been on them for years at a fairly high dose. Let's say if all of a sudden you stop taking those glucocorticoids, well, your body isn't used to normally making those glucocorticoids anymore because you've been taking them exogenously for years. But if you stop taking those, all of a sudden your glucocorticoid levels will drop out and get really low, and the tissues that normally would make glucocorticoids will be atrophied because you haven't used them in years, right? And so that can lead to hypofunction as well. And we'll talk about a disorder where that can occur. Or tissue resistance can occur for hypofunction as well. Tissue resistance is where tissues stop responding to a hormone as well. I like to think of this as like the unruly child. Like there's the kids that are always bad, and because they're always bad, they don't even respond to being yelled at anymore because they're so used to being yelled at that they're like whatever. Like I was yelled at 2 minutes ago, and then they stop responding, right? Well, what if for tissues in your body, if your hormone levels are high for so long and your tissues just stop responding to those hormones? That can happen. And that's actually what we call tissue resistance. One of the factors that influences tissue resistance is downregulation. So downregulation is when these cells actually start to remove receptors from their membrane to respond less to those hormones. That some etiology of endocrine disorders can be congenital, autoimmune, or neoplastic. Congenital could be like an inborn genetic defect that can result in excess or deficiencies in hormone production. Autoimmune could be like a genetic predisposition or environmental trigger that causes antibodies to attack self tissues. Remember, those antibodies can both damage and lead to hypofunction or simulate and lead to hyperfunction. So it depends on what's going on here. Or neoplastic conditions where you might have a growth of some tissue. It could be non-secreting or secreting. If it's secreting tumor, that can lead to hyperfunction. If it's non-secreting, that can lead to hypofunction where the tumor might impinge on nearby tissues. Some functional disorders can include things like as a sequela or consequence of other organ system failure, you might get an endocrine disorder. Like for instance, we know the kidneys release erythropoietin, right? We understand that one of the sequelae of kidney failure is anemia because the kidney stopped being able to release erythropoietin, right? That would be a functional disorder. Or if the liver stops being able to respond to certain hormones, that can be a functional disorder, okay? Now, tissue resistance occurs when a target tissue fails to respond to a hormone. Typically, what causes resistance is just hormone concentration that's too high for too long. And because the signal's there so long, the cells stop responding to it, right? An example of this is insulin. And we'll come back to this later with diabetes. But what if you had a diet high in sugar? Not low in sugar, but high in sugar. Then you're going to be releasing insulin pretty frequently to get that blood sugar low, which means that your insulin levels are going to be high for long periods of time. Well, what happens is over time, your body's cells stop responding to that insulin. Although it's there, they get tissue resistance because of downregulation. So what that means is the insulin's there, but it's not exerting an effect because now the cells have started to remove those insulin receptors and they're not responding to that insulin anymore. That would be considered type 2 diabetes, so we'll come back to that later. That's a form of tissue resistance. But you can get other forms of tissue resistance too, if you're exposed to too much of a particular hormone for too long. Now, iatrogenic is just basically caused by unintended or unwanted medical treatment. So you might see that someone has like an endocrine gland accidentally removed. Maybe they go in for a nephrectomy and maybe the surgeon accidentally also removes their adrenal gland. Or they go in for a thyroidectomy and the surgeon accidentally removes their parathyroid glands. Okay. Now, treatment for endocrine hyperfunction could be like removal or destruction of glandular tissue, which can result in chronic hypofunction, but that's replaced with sort of a long-term hormone replacement therapy, right? Like, so if someone has a thyroid tumor and that requires surgical removal of that tumor, then they're not going to be able to make their own thyroid hormone. But what that would mean then is that although that could lead to chronic hypofunction, they would need to take thyroid hormone exogenously for the rest of their life in order to maintain that function. Now, classification of endocrine disorders can be primary, secondary, and primary disorders are where we have an intrinsic malfunction of that hormone-producing gland. Secondary disorders are where we have abnormal pituitary secretion of trophic signals. And because these clinical manifestations are similar, you can use blood levels of the hormone to figure out where the disorder is coming from, right? So for instance, let's say if you wanted to suss out why someone had hyperthyroidism, right? Their thyroid hormone levels are out the roof, but you don't know if that's because of a pituitary problem or a thyroid problem. It might be that the pituitary is releasing too much TSH, which is then stimulating the thyroid gland to release a lot of TH, or it could be that the thyroid gland is releasing an excessive amount of TH on its own accord due to like an endocrine secreting tumor of some sort. So you would need to look at blood levels of those hormones to figure out where the problem's occurring, and that can help you to differentiate between a primary or secondary disorder. So in primary disorders, when the gland fails, what we see that is an inadequate hormones produced. So you get low levels of a circulating hormone, and the blood levels of the corresponding trophic hormone will be elevated. I'll give you as an example. Let's say if someone had congenital hypothyroidism or like thyroid dysplasia, where the thyroid gland just never even developed in that infant. Okay. What we'll find then is their pituitary gland can still release a tremendous amount of TSH. So the TSH levels will be high, but because they don't have a thyroid gland, their TH levels will be extremely low or non-existent, right? And that's how we can tell it's a primary disorder, because we can see that the hormone that stimulates the endocrine gland is present, but the endocrine secreting gland or hormone secreting gland isn't responding. That's how we know it's primary. Okay. Secondary is going to be where the pituitary gland fails to release its trophic hormone, and you're also going to see a correspondingly low level of the the next hormone from that gland. So I'll give you an example. Let's say if someone had low thyroid hormone levels, and you wanted to figure out whether there's a problem with the thyroid gland or the pituitary gland. Well, then you would want to look at pituitary TSH as well, right? So what if their TSH levels were low and their thyroid hormone levels were low? Well, that suggests not a problem with the thyroid. That suggests a problem with the pituitary, because the pituitary is what's releasing TSH to stimulate the thyroid. And so that would be a secondary disorder. So what if you had a patient that had really high TSH but low TH? Would that be primary or secondary? Primary, right? Because their thyroid isn't responding. Or what if they had really high TRH? Actually, let's not go there. Never mind. We'll leave it at that. So let's talk about some growth hormone disorders, you guys. Now, growth hormone is produced by your anterior pituitary gland, and it's stimulated to be released by growth hormone releasing hormone by the hypothalamus. Its main target is the liver and skeletal tissues. It helps increase lean body mass, reduces fat mass by increasing the production of free fatty acids in bloodstream, causes your liver to release glucose under conditions of hypoglycemia, and it makes sense you'd want to release free fatty acids and glucose while growing, because these nutrients would help support growth of those skeletal tissues like bone, muscle, tendons, ligaments, and adipose. Now, growth hormone deficiency can be caused by a midline brain tumor, which would affect the pituitary gland. It could also be caused by radiation or leukemia or trauma to the skull. Some clinical manifestations of growth hormone deficiency would be growth below the 3rd percentile. What this means, you guys, if it's below the 3rd percentile, is that 97% of all other children are growing faster than that child, right? If you're below the 3rd percentile, 97% of all the children are growing faster than that child. So this suggests that they're growing very slowly, and that they're, maybe their growth is actually going to be abnormal. You might also see hypoglycemia as well, knowing that growth hormone helps to increase blood sugar, thin hair and poor nail growth from low blood sugar, greater fat mass because now you're not actually stimulating the release of free fatty acids, as well as decreased muscle mass and delayed bone formation because now you don't have growth hormone to stimulate skeletal tissues, and delayed puberty because growth hormone plays a role in stimulating puberty. Now, growth hormone excess can occur either in children or adults. When growth hormone excess occurs in children or sort of adolescents, we call this pituitary gigantism. If it occurs in adults, we call it acromegaly. But when I refer to children, you guys, I'm talking about humans whose epiphyseal plates haven't fused yet. Like their growth plates are still unfused, and it's still cartilage. So that means growth hormone can stimulate those epiphyseal plates to elongate. So if you get growth hormone excess before those plates have fused. With pituitary gigantism, this is where individuals get really tall. When you start talking about humans that are like 8 or 9 feet tall, I don't know if anybody's ever been 9 feet, but that's pretty tall, right? That's probably pituitary gigantism, where they had growth hormone excess before their epiphyseal plates could fuse, right? That differs from acromegaly because this is growth hormone excess in adults. The epiphyseal plates have fused. They will no longer grow lengthwise, but other tissues will grow larger, right? So what do you guys think acromegaly would look like then if they can't grow lengthwise? Which other way could they grow? Yeah, the bones can get thicker. So you can see an increase in the thickness of like facial bones and just bones throughout the body. Muscle gets also more dense, in part because growth hormone stimulates muscle growth, but also because their bones are getting thicker, they're going to have a heavier skeleton, which means you need more muscle to move that skeleton around, right? Now, you might wonder, what causes growth hormone excess? Well, anything that causes hyperfunction or hypersecretion, right? So you can have a secreting tumor of the pituitary gland, which might lead to growth hormone excess. Now, what this slide showed you guys is acromegaly. So if it's acromegaly, is that growth hormone excess in children or adults? Adults, right? So do you guys notice like on her facial features have changed over time? So what's different between this lady and this lady, although they're the same lady? Just through the disease progression. This looks like maybe 60s, 70s, late 70s, maybe 80s, I don't know, and then maybe like late 80s, 90s. So across the decades, right? I don't know. I'm trying to go off hairstyle here, you guys. I don't know. Thank you. And maybe just have the photos appear. So what's different about her face?
Her jaw is a lot.
Yeah, jawline is much more prominent. Nose is larger. Nose is made of cartilage, right? So even the nasal cartilage got larger. How about cheekbones? Maybe a little different. And you can't tell because the hair is kind of covering up here, you guys. But if you look at her orbit, especially the brow line here, you'll see that there's a more prominent brow line. And that's due to growth of the bone on the frontal bone there. Okay. How about her lips? Larger, right? From more collagen deposition. And so how about adipose? A little bit more adipose. And that may or may not be caused by the growth hormone excess, but just an observation. And so this is an example of acromegaly. Would you want to have acromegaly unchecked? No, because what's it causing? Well, growth of skeletal tissues. Imagine if your bones got so thick that nerves started to get cut off. That can happen. Or also this causes hyperglycemia or chronically elevated blood sugar. We'll learn later that hyperglycemia actually damages your body's tissues. You don't want high blood sugar chronically because sugar actually damages your tissues. They're now calling sugar a toxin, by the way. It's interesting. So we'll learn about that later. So what about thyroid hormone disorders? Well, there's two forms of thyroid hormone, T3 and T4, and they're released by the thyroid gland from our thyroid follicles. And what stimulates the thyroid gland to release thyroid hormone is TSH from the anterior pituitary. And thyroid hormone is one of the main regulators of metabolism. It regulates basal metabolic rate, or BMR. And this basically gives a set point, or a point at which how much we metabolize things at any given moment. And that's determined by thyroid hormone. What's crazy, you guys, is that the receptor for thyroid hormone is actually on mitochondria. So thyroid hormone diffuses into your body's cells, binds to the receptor on mitochondria, and then determines the speed at which those mitochondria use nutrients to make ATP. That's actually pretty cool. So it's also used for normal growth and development of tissues. So if someone had hypothyroidism during development, you're going to see some pretty dramatic developmental deficits. Okay. So hypothyroidism, you guys, is just basically low thyroid hormone level, and it can be congenital or acquired. The majority are a primary disorder from like intrinsic gland dysfunction. And if it's congenital hypothyroidism, we call this cretinism. You know, cretin is a adjective we use, and it's sort of derogatory, right? Like when you call someone a cretin, they're kind of usually defer. Like I feel like that would be used to describe someone who's sort of like slovenly lazy, or like just obese, and in a lot of ways not necessarily a good word to use. But clinically, cretinism refers to congenital hypothyroidism. Okay, Now, what this means is the thyroid gland just fails to lack in these infants, but because thyroid hormone is so vital to development, their tissues don't develop fully, especially the nervous system. So you see underdevelopment of the nervous system causing severe mental retardation and deficiencies in growth of most tissues, so they're also much smaller than normal. Secondary hypothyroidism can be due to deficits in TSH production from like a anterior pituitary tumor of some sort, and it's associated with head and brain conditions. Because the pituitary gland sits right on the midline of your skull, right in the sella turcica. If you get head injury, or if you get some intracranial pressure, it can really affect the pituitary gland. And it's also housed in a bony cavity, so if it swells, it can't expand beyond that bony cavity. So head trauma can also lead to secondary hypothyroidism or exposure to radiation, tumors, that kind of stuff. So the most common cause of acquired hypothyroidism, you guys, is called lymphocytic thyroiditis or Hashimoto's disease. Hashimoto's disease is an autoimmune disease where your immune system starts to attack your own thyroid cells. Okay, so with Hashimoto's thyroiditis, what we see here is that your immune system attacks the follicular cells of your thyroid, and you get bouts of hyperthyroidism followed by hypothyroidism. Whoa, how does that work? Okay, well, it kind of makes sense if you think about it from the standpoint of if your immune cells are killing off thyroid-containing cells, when those cells die, they burst open and they start spilling out thyroid hormone into your bloodstream. That would cause the hyperthyroidism, right? But because the cells are now gone, you can't make additional thyroid hormone, so then that's followed by bouts of hypothyroidism. So initially, Hashimoto's disease presents as hyperthyroidism, but then as the disease progresses and your immune cells start to kill off your thyroid cells and you don't have any thyroid cells left behind to make more thyroid hormone, that results in hypothyroidism. That's the most common type here, but it starts as hyperthyroidism. Okay. Now, it can also be caused by irradiation of the thyroid gland or surgical removal of thyroid tissue or even iodine deficiency. We don't have to worry about iodine in our diet nowadays because we have iodinized salt, right? Like the salt that we typically eat in our diet contains iodine because it was artificially or fortified with iodine. Now, if you live in a part of the world where you're not around iodinized salt, or you don't have a diet high in iodine, it can lead to hypothyroidism because we need iodine to make thyroid hormone, right? And this is why it's called T4 and T3. In fact, T4 has 4 iodine atoms. T3 has 3 iodine atoms. So it actually takes a lot of iodine to make thyroid hormone. And what's neat, though, is that our thyroid glands can store about a year's worth of iodine. So let's say if you didn't have iodine in your diet for an entire year, you could still make enough thyroid hormone to maintain your homeostasis. That's how much iodine is stored in your thyroid. So that's kind of nice. Otherwise, if you didn't have enough iodine in your diet, you guys, this will lead to goiter. Let's think about this. If you didn't have enough iodine to make thyroid hormone, what would your blood levels of thyroid hormone be? High or low? You don't have enough iodine to make thyroid hormone. So blood levels of thyroid hormone will be low. Your pituitary gland starts making more TSH to try to stimulate your thyroid to release more thyroid hormone. But the problem isn't the fact that the thyroid's not releasing thyroid hormone. The problem is the fact that you don't have enough precursor molecule to even make thyroid hormone. But your pituitary gland still secretes TSH. In the long term, and someone mentioned this earlier, due to excessive TSH exposure, it causes your thyroid gland to grow large and it forms a goiter. And the goiter is just an enlargement of your thyroid gland due to high TSH levels. And so you see goiter in people with iodine deficiency. They can get really big sometimes. I don't know if I have a picture of this. Yeah, here we go. So this is showing goiter right here, you guys. Let's just assume that it's caused by iodine deficiency. What's causing your thyroid to get larger if you don't have iodine here? Why is your neck getting large? Go ahead. Yeah, you got a lot of TSH being released by your pituitary gland, and then TSH stimulates the thyroid gland. It's growing in response to TSH. Your body thinks the problem is the thyroid gland's just not active enough, right? So it starts releasing more TSH. The problem here, though, is that you don't have enough iodine in your diet to even make thyroid hormone. And so your body's solution then is for your thyroid gland to just grow larger. Why not? Got a larger thyroid gland, that should mean more thyroid hormone. But the problem here is a deficiency in nutrient, which is iodine. And It can, yeah.
And does it happen rapidly or no?
No, it's not really rapidly, no. I mean, it's going to take years to progress, like to this large. Now, it depends on what causes the goiter, though. If it's goiter caused by iodine deficiency, this will progress fairly slowly because you'll slowly run out of iodine. If it's goiter caused by a thyroid tumor, it could be as fast as that tumor grows. And knowing that tumors can grow pretty quickly, and it may progress quickly. But not all goiter is caused by iodine deficiency. Some goiter is just caused by thyroid tumors. Now, hypothyroidism, because it's low thyroid hormone levels, you guys. Remember, thyroid hormone's involved with regulating basal metabolic rate. So if your thyroid hormone levels are low, then we're going to see things like weakness, lethargy, cold intolerance, and decreased appetite. How about body temperature? Decreased. So they're going to have hypothermia, right? Bradycardia, because it also affects muscle contraction. So you see slow heart rate and narrowed pulse pressure because their heart muscles now weakly contracting. Mild to moderate weight gain because their metabolism is so slow that they're not using their body's nutrients. Elevated cholesterol and triglycerides, that's common with hypothyroidism, as well as enlarged thyroid, dry skin, and constipation. Remember, you get constipation here because of decreased GI motility. Because thyroid hormone affects muscle contraction, you'll see that people with hypothyroidism are more prone to constipation. How do we define constipation back in the GI unit? Y'all remember? Yeah, less than 3 bowel movements per week. Good. It can also lead to depression and difficulties with concentration and memory. And this is due to deficits of neurological function. Loss of eyebrow. You might wonder, why is that? Well, it leads to decreased hair growth all over. But it's especially prominent on the eyebrow because eyebrow hair is already pretty thin, right? And it's also fairly short hairs. So you'll see a loss of eyebrow hair, and it's prominent because it's easy to see. That's due to hypothyroidism. And if it's females, you might see some menstrual irregularities as well. Now, hyperthyroidism has the opposite etiology, right? You're talking about how it's high thyroid hormone levels, and it could be primary or secondary. If it's primary hyperthyroidism, why are we getting an excessive release of thyroid hormone? If it's primary hyperthyroidism. A problem with the thyroid gland itself. Good. So this could be a secreting tumor of the thyroid gland where you might get an excessive amount of thyroid hormone being released from that tumor. What if it's a secondary disorder of, good. So it could be a pituitary tumor causing a lot of TSH to be released. That TSH then can stimulate the thyroid gland to release a lot of thyroid hormone, and then that could lead to hyperthyroidism. Good. Now, we also talked about Hashimoto's thyroiditis, you guys. Which disease was this again? It starts high, then goes low. But what is, like, as a disease, what is Hashimoto's?
It's an autoimmune disease that attacks where your body starts attacking the thyroid.
Nice. Autoimmune disease where the body starts attacking the thyroid tissue itself. Why does it first start out as hyperthyroidism?
Because you're lysing open the thyroid.
Nice. You're lysing open those thyroid cells. Thyroid hormone spills out in the body. But then what are you left with? Well, no thyroid cells, right? So then it's followed by hypothyroidism. But it starts as hyperthyroidism. It's important to talk about because it's one of the most common forms of thyroid dysfunction. Now, if it's primary disorder, you guys, we talk about Graves' disease. Graves' disease is an autoimmune disease. It's kind of weird, you guys, but it's an autoimmune disease where B cells make antibodies against TSH receptors. Remember, TSH receptors you find on the thyroid. They're going to respond to TSH. But what if I told you all that these antibodies bind to TSH receptors and activate those receptors so that these antibodies simulate TSH? And so it's not even TSH itself. You're just talking about antibodies that actually activate TSH receptors, which is causing an excessive release of thyroid hormone level, or thyroid hormones. Secondary would be excessive release of TSH by a pituitary tumor of some sort. It could be like a microadenoma or even just a full-on adenoma of the pituitary gland. And it's just hypersecretion of TSH. So what this is showing you guys is some of the common clinical features of hyperthyroidism. For one, you get exophthalmos. Exophthalmos means protruding eyes, which is what we see here. I know this picture looks like she's like excited or maybe scared. But what's interesting here, though, is this is like a kind of a more resting face, and the reason why the eyes are protruding outward is that due to a deposition of adipose behind the eyeballs will protrude outward, and this is what causes X-ophthalmos. It can be reversible. Sometimes it's permanent. So sometimes people with hyperthyroidism have X-ophthalmos. They get their hyperthyroidism treated, but it doesn't reverse. So they're kind of stuck with this, this sort of look, which is unfortunate because people will kind of treat you differently and respond to you differently. Now, palpebral fissure is actually basically where the palpebra or eyelids can get really thick due to adipose deposition in the eyelids, and it actually causes the eyelids to be more droopy. And that's another sign of hyperthyroidism on the face. Hyperthyroidism. Some of the clinical manifestations, we're talking about how having high thyroid levels. So hypermetabolism will lead to changes in behavior, insomnia, restlessness, tremor, irritability. This just comes from excessive, nervous system excitability, palpitations, heat intolerance. In fact, they're going to be kind of hyperthermic. Diaphoresis, diarrhea from increased GI motility, right? Because thyroid hormone makes their metabolism so fast that their smooth muscle becomes really excited. Inability to concentrate, that interferes with work performance, and as well as an enlarged thyroid gland. That may be sort of symptomatic of hyperthyroidism. And you're going to see an increased basal metabolic rate that leads to things like weight loss and appetary and dietary intake, as well as amenorrhea and scant menses. Now, some people will attempt to take thyroid hormone illegally, even if they don't have hypothyroidism. The idea being that if they can artificially increase their basal metabolic rate, then they can lose weight, right? But we've learned that if you take a hormone exogenously, then your body stops making it itself, and so that if you stop taking that hormone, then you're not ready to start making that hormone yourself. So then your hormone levels even drop out. So I would imagine then that if someone did take thyroid medication to try to lose weight, after they stop that, they would probably gain that weight back because of the hypothyroidism that would ensue from that. So it's kind of interesting. Now, we're going to move on to talk about the adrenocortical hormone disorders. So we learned earlier that the adrenal cortex synthesizes glucocorticoids, mineralocorticoids, and androgens. The glucocorticoids include things like cortisol, and it's involved with negative feedback that's based on the release of ACTH. And mineralocorticoids include things like aldosterone, which relates to the whole RAAS, or renin-angiotensin-aldosterone system. And androgens are basically the sex hormones that come from those gonatocorticoids. Now, we'll first talk about this adrenocortical insufficiency, and there's primary, secondary, and tertiary insufficiencies. A primary adrenocortical insufficiency is due to a disease of the adrenal cortex, right? Like if the adrenal cortex itself is damaged, that's the endocrine secreting gland here, right, the end part. So we call it the primary deficiency. Secondary would be an issue with the pituitary gland not secreting enough ACTH. And then tertiary is a hypothalamic issue. Like if the hypothalamus were damaged and it weren't releasing CRH to stimulate that anterior pituitary to release ACTH, that can lead to insufficiency as well. So cortisol insufficiency is the most clinically relevant because it's most important for your metabolism. Now, some of the clinical manifestations of adrenocortical insufficiency include things like anorexia, weight loss, salt wasting from a lack of aldosterone, weakness, malaise, apathy, electrolyte disturbances, again from aldosterone insufficiency, as well as hyperpigmentation of skin, and hypoglycemia, which comes from the lack of cortisol, and hyperkalemia, which comes from the lack of aldosterone. Because remember, we learned that aldosterone is involved with potassium secretion, as well as sodium reabsorption. So if you lack aldosterone, then you're going to have high blood potassium levels, because then you have a good way to get rid of that potassium. You're going to see things like diminished vascular tone and reduced cardiac output from basically the electrolyte disturbances, as well as inadequate circulating blood volume, because if you can't hold on to your body's sodium, then you start increasing urine output, and then you have a lower blood volume, which lowers blood pressure, and this can lead to cardiovascular collapse. And what we call this is Addisonian crisis, or acute adrenal insufficiency. And it's a life-threatening condition that's caused by inadequate levels of glucocorticoids and mineralocorticoids that can lead to circulatory collapse. It can occur from acute withdrawal of corticosteroids. We talked about this earlier, how if someone's taking a corticosteroid for immunosuppression, and if they acutely withdraw that steroid rather than taper it down, their adrenal glands may not be ready to make their own cortisol, so that can lead to adrenocortical insufficiency that may be life-threatening. And this may require some intravenous glucocorticoids or volume replacement. Now, this differs from hypercortisolism, and we have Cushing's disease as well as Cushing's syndrome. Cushing's disease is actually a term that's used to describe basically hyperstimulation of the adrenal cortex, where you give a lot of cortisol. Cushing's syndrome is used to describe high cortisol for some other reason other than excessive stimulation of the adrenal cortex. So Cushing syndrome could be caused by like a secreting tumor of the adrenal cortex. So primary, again, that's a cause of adrenal cortex. Secondary is actually dysfunction of the pituitary, and tertiary is a hypothalamic dysfunction. Now, some of the signs and symptoms of Cushing syndrome we see here, it's basically hypercortisolism. A couple things, you guys. For one, we got what they call buffalo hump. Buffalo hump is this dorsocervical fat pad, and due to high cortisol levels, adipose has a tendency to accumulate right here on the superior part of their posterior thorax, and they call it the buffalo hump or dorsocervical fat pad. That's one thing that's characteristic of hypercortisolism. They also get sort of thinning of the extremities, so a little bit of muscle wasting, some truncal obesity and adiposity here, as well as blue-purple striae due to weakening of the skin, ecchymoses from weakening of the blood vessels, so they're small hematomas that can occur here, thin, fragile skin, so they might have some wounds that occurred from not a whole lot of trauma, very fine hair, as well as what we call moon face. Moon face is basically where, due to an accumulation of adipose, they have a kind of a loss of facial features. Instead, the facial features kind of become more rounded, rather than having like complete jawline or prominent cheekbones. Things just kind of fill out, and it looks more circular, sort of moon-shaped. So they call that moon face or ruddy complexion. The ruddy complexion is going to be kind of a redness of the cheeks. You can also see that with hypercortisolism, as well as hirsutism. Hirsutism is hairiness. So hairiness is also a complication of hypercortisolism. Now, what we see here then is Cushing's syndrome before and after surgery. So here's before the surgery, and they might have had like a secreting tumor of the adrenal gland, and this is after surgery, and you can see that it's the same person actually, but with the eyes kind of whited out, it's kind of hard to tell it's the same person because the facial features are so different. Over here, you can see that due to an increase in the adiposity of the face, they have kind of more of a circular kind of face shape, and you can't really see the cheekbones or jawline very well, as well as we call it the ruddy complexion, which is sort of a redness of the cheeks that comes about from hypercortisolism as well. This is after surgery where her face kind of thinned out and that ruddy complexion went away. Now, hyperaldosteronism, it's also a condition of the adrenal cortex, but this is due to aldosterone. We know that aldosterone is one of those hormones that helps you retain sodium but secrete potassium. So you can imagine then that hyperaldosteronism is going to lead to abnormally high sodium levels or abnormally low potassium levels, so hypernatremia and hypokalemia. Now, the primary cause of hyperaldosteronism is actually Conn syndrome, and this is usually due to an aldosterone-secreting tumor somewhere in the body. Secondary causes can be from poor kidney perfusion that stimulates the RAAS, and so you get too much aldosterone being released from renal failure, and aldosterone facilitates saltwater retention, like we talked about. So some of the clinical manifestations will be hypertension from excessive water reabsorption, as well as hypervolemia because you're retaining so much sodium that you retain water, and hypokalemia from excessive potassium secretion into urine. Now, for the disorders of the adrenal medulla, we got Pheochromocytoma, which is basically a secreting tumor of the adrenal medulla. And with Pheochromocytoma, this tumor grows, but as it's growing, it's also secreting a tremendous amount of epinephrine and norepinephrine. So that what we end up with then is actually excessive sympathetic nervous system stimulation, where these catecholamines like epinephrine and norepinephrine increase heart rate, blood pressure, and glucose from the liver. And this can result in excessive production and release of these catecholamines. Now, some of the clinical manifestations of pheochromocytoma include things like hypertension, headache, tachycardia, diaphoresis. This makes sense because these are all, symptoms of the sympathetic response, right? As well as tremor, nervousness, emotional lability, pallor, fatigue, orthostatic hypotension, as well as hypermetabolic state. And these are all just sort of consequences of a chronically elevated sympathetic response. Now, we learned earlier that the parathyroid glands release parathyroid hormone, which acts to raise your blood calcium. So you can imagine then that if someone had a parathyroid disorder, then they're going to have blood calcium dysregulation. And so normally our parathyroid glands, those chief cells, sense calcium levels in blood. If blood calcium levels are too low, they release parathyroid hormone, which acts to raise blood calcium. And it does this through a variety of means. It can do this through resorption of bone or breakdown of bone. It can do this through reabsorption of calcium by your kidneys, or stimulates the release of vitamin D by your kidneys to release more calcium from your gut. So if you have vitamin D deficit, then this can also impair calcium absorption, which can lead to hypocalcemia. But hypocalcemia will cause parathyroid hormone to be released, which would try to increase vitamin D production and release by your kidneys. So what this slide has shown you guys is just sort of this normal feedback mechanism we just talked about. So low serum calcium leads to parathyroid hormone secretion. It causes bone resorption, reabsorption of calcium by the kidneys and release of vitamin D, as well as reabsorption of calcium at the level of the gut. All of these act to increase serum calcium levels, and when blood calcium levels are restored to normal homeostatic levels, then you stop releasing parathyroid hormone, and that's the feedback mechanism. So it's negative feedback here. Now with hyperparathyroidism, it can be caused by a variety of conditions, like it could be idiopathic, genetic, or you might have a parathyroid adenoma. What's interesting, you guys, is that there are some parathyroid hormone secreting tumors. Like there are parathyroid secreting lung tumors that can occur. Now it's not as though it's parathyroid gland tissue. It's just for some reason, these lung cells, when they become tumorous, can sometimes release parathyroid hormone. So you get these ectopic sites of release of parathyroid hormone, which can lead to hyperparathyroidism, including lung tumors. So, or you might also see this from reduced vitamin D levels in the blood. And what this causes then is bone resorption. Makes sense. And because of this hyperparathyroidism is caused by the bone resorption, and it leads to it's caused by excessive parathyroid gland secretion. And these malignant cells can release parathyroid-like hormone, which can lead to hypercalcemia crisis, bone resorption, excessively high vitamin D levels, and hypercalcemia. Now, the clinical manifestations of this are going to be things like kidney stones, as well as bone demineralization. The reason why you see kidney stones forming, guys, is that your blood calcium levels get so high that your kidneys, although in response to parathyroid hormone, they're trying to reabsorb calcium, you can overload your kidney's ability to reabsorb that calcium, so you still end up with calcium in the urine. That can form these calcified deposits, the calculi, that can lead to kidney stones. Now you see bone demineralization, because that's one of the effects of parathyroid hormone, as well as polyuria, because if you have a lot of calcium in urine, then that can also attract water with it, so it can lead to excessive water loss and dehydration. In fact, we learned about how with bone, you either use it or lose it, right? So it's a different process here, but I just want to mention something it's kind of cool. They're actually measuring calcium in the urine of astronauts to figure out what percent of their bones they're losing through urine. It doesn't really relate to the parathyroid mechanism, but it's still kind of interesting how you can lose a lot of calcium through urine. Now, with respect to hyperparathyroidism, this can lead to kidney stones, calculi in urine. Now, high serum calcium levels can decrease neuromuscular excitability, but can also lead to things like anorexia, nausea, vomiting, constipation, bradycardia, heart block, and cardiac arrest. It makes sense because, if smooth muscle regulates GI motility and cardiac muscle regulates your heart, if hypercalcemia causes decreased neuromuscular excitability, then you can expect to see decreased GI motility, decreased heart rate, bradycardia, and low blood pressure as a result. Now, hypoparathyroidism can be idiopathic or autoimmune. Secondarily, it can be caused by parathyroid or thyroid surgery, and it can occur with removal of the parathyroid glands. And in fact, often if they remove the thyroid gland, you guys, the parathyroids are lost with it. It's pretty challenging to keep your parathyroids if someone has a thyroidectomy. So they typically remove both. Now, the congenital lack of parathyroid tissue can occur as well. So you can see this as hypoparathyroidism in children and infants. Now, the clinical manifestations of hypoparathyroidism are all those things you'd expect to see with hypocalcemia, right? So increased neuromuscular excitability. So you're going to see things like circumoral numbness, paresthesias, muscle cramps, spasm, hyperirritability, anxiety, depression, prolonged QT intervals, and increases in intracranial pressure due to high blood pressure. Makes sense from increased neuromuscular excitability. Some of the more severe symptoms, you can see things like carpal pedal spasms. And by the way, a carpal pedal spasm is basically where, like, all of a sudden someone's wrist might twitch, right? Or their foot might twitch, just in those specific areas there. You might see laryngospasm where the glottis closes off. With laryngospasm, someone can actually have dysphagia, so difficulty swallowing or breathing, okay? And it can also lead to seizures, tetany, and these are all manifestations of this decrease in neuromuscular excitability from hypocalcemia. Now, antidiuretic hormone we learned about, that was released by your posterior pituitary gland. It's also called vasopressin. On the kidneys, it helped increase water reabsorption, right? So its normal function is to act on the renal collecting tubules and helps reabsorb water. That way it creates a smaller volume of highly concentrated urine and helps you retain your body's water. Now, the first disorder of ADH we'll talk about is diabetes insipidus. Now, this has nothing to do with diabetes mellitus, which we'll talk about in a little bit. Diabetes insipidus is excessive water loss, and it comes about from some sort of deficiency in this whole ADH mechanism. Okay, so there's different causes of this, but it's basically insufficient ADH activity that causes excessive loss of water and urine, and with that excessive urination, that's what we call diabetes. Okay. Now, with damage to the hypothalamus, you might see that someone might not have the ability to release antidiuretic hormone, and that can lead to diuresis or water loss. In fact, alcohol also inhibits ADH release, because we know that alcohol is a depressant, and as a depressant, it inhibits your neurons from releasing antidiuretic hormone. So if you don't release ADH, then you don't retain your body's water, so you actually end up having to urinate more. And that's one of the reasons why alcohol is a diuretic, is it actually inhibits this whole ADH system. Now, centrally, it could actually be a problem with the hypothalamus or pituitary, where you just might not get the release of ADH. Nephrogenic diabetes insipidus could be where you have tissue resistance to ADH. Like, it's possible that your kidneys just stop responding to antidiuretic hormone. So although the hormone's present, that could actually lead to excessive water loss. Now, that's what we call nephrogenic diabetes insipidus. Now, some of the clinical manifestations here, well, polyuria, which means excessive urination. Polydipsia, because you're going to have excessive thirst from that excessive urination. Low urine-specific gravity, right? You have a lot more water than solutes inside your urine, as well as nocturia. You know, people have to wake up multiple times in the evening or a night just to pee because they're creating urine so quickly that they can't get a full night's sleep. You can see hypernatremia due to water deficit and all of the sequelae with that, as well as dry mucous membranes, poor skin turgor, as well as decreased saliva and sweat production from dehydration, and disorientation, lethargy, seizures from shrinkage of your brain tissue. And these are all manifestations from your body cells shrinking. Now, there's also one called syndrome of inappropriate antidiuretic hormone. If you think about this, normally ADH helps you to retain water when your blood volume's low, right? Or your blood pressure's low. The syndrome of inappropriate antidiuretic hormone is that when you're releasing antidiuretic hormone when you don't need to retain water. That's why it's inappropriate. So this syndrome of inappropriate antidiuretic hormone occurs when somebody has like hypertension or volume excess, but they still get the release of antidiuretic hormone, which causes them to retain more water. So this excessive ADH can come from ectopic production of it from tumors, like lung malignancies can produce ADH, just like lung malignancies can produce parathyroid-like hormones. And excess ADH can stimulate the renal tubules to reabsorb too much water, which increases blood osmolality. Adrenal insufficiency and hypothyroidism can also cause increased ADH secretion and hyponatremia. So what this slide shows is a nice summary of the sequela of syndrome of inappropriate antidiuretic hormone. So what we see here is that with excessive antidiuretic hormone release, we get a lot of water reabsorption by our renal tubules, and that does two things. For one, it increases our plasma volume from fluid overload, And 2, it causes dilution of your body's tissues, so you get hyponatremia from basically diluting out your body's sodium. And from this increase in plasma volume, what you'll find is you'll see this will increase GFR. And when GFR is faster, you get more sodium filtration, which means you get some more sodium excretion, which leads to hyponatremia. And then if your plasma volume is also high, which means your blood pressure is high, you won't get as much aldosterone secretion, because aldosterone is released when your blood volume and blood pressure are low as a consequence of the RAAS, right? Which means you get less sodium reabsorption, which again leads to hyponatremia. So hyponatremia as an electrolyte disturbance caused neuromuscular excitability or neuromuscular depression. Do you guys remember? So hyponatremia causes neuromuscular excitability or depression? Depression. So hyponatremia will lead to a decrease in the excitability of your neuromuscular system. So what do you guys think would be some clinical manifestations of hyponatremia if it prevents your nervous system and muscular system from being as excitable? Let's think about the heart. Bradycardia. How about your blood pressure? Yeah, decreased blood pressure. Good. How about cognitive functioning? Decreased, slowed, right? How about GI motility? Also slowed. Exactly. Good. So how about sensitivity of receptors like on your skin? Also decreased. Yeah, good. And those are sequelae of hyponatremia. Good job, you guys.